Thank you, Heidi. And I know that many of you have heard this, some of this already, but I know there are new faces here. And I want to frame what we're doing in the Global Alliance in terms of the opportunities, the challenges and the opportunities ahead of us. Okay. So we are going through a process of remarkable change in genomics. And the most important thing to realize is the majority of the genomes sequenced in the future will be sequenced for a healthcare reason, not for a research reason. And this is going to fundamentally change how many genomes we have, but also fundamentally change the dynamics of how we access those genomes. We've made an estimate of the number of these with really conservative assumptions. We think that there will be at least 60 million human genome sequences by 2022, driven primarily from these two major clinical areas, rare disease and cancer. The reason why these genomes are being sequenced is because it's effective in clinical healthcare. The most obvious case is in rare disease. It has become very obvious that sequencing a child or a person's genome with a suspected rare disease will profoundly change their life and their family's life as well. Between 20 to 30% of people with a suspected rare disease, when they have their genome sequenced, will get a diagnosis, and this compares to about 5% under previous standard routine care. Cancer is far larger. 1 in 2 of us will be diagnosed with cancer over our lifetime. Now, cancer is a disease of the genome. The genome very often is altered, nearly always is altered, and is the reason why cancer cells divide. At the moment, when cancer patients have genomic sequence, this informs clinical decisions about 10% of the time. But the broad clinical research community, some of whom are in this room, I think there is real confidence that that number will steadily grow over the next coming years. And it's important to realize for the researchers in the room that the economics of healthcare is very, very different from the economics of research. Firstly, it's far larger. Most countries spend at least 10-fold, perhaps 100-fold more on healthcare than they do on research. Healthcare has an obsession in many places with cost control, quite appropriately. It's a very expensive process. But the flip side of this obsession with cost control is that when costs are justified and approved for a medical procedure, it will nearly always be rolled out to all the patients where it's useful. And so one is not limited by, in some sense, the research money one has. One is limited by the applicable size of the population for that part of healthcare. So we made a crude model, a crude and conservative model of how many genomes we believe is going to happen over the next decade. It gets to an incredibly large number. So this is 350 million at the end there. And if you look at 2022, we're just above 60 million genomes around the world. It could easily be far larger than this. These are quite conservative assumptions of how quickly genomic medicine penetrates into different countries across the planet. Now, this is great for people involved in genomic research. We have been talking about this for 20, 30 years. It is a wonderful moment, but it gives us 3 extra things to do. We have a responsibility. For researchers, we have an opportunity, and there are many challenges to overcome. So the responsibility is that much of the technical know-how of how to do genomics is really in the research community. And we need to help that technical know-how join the technical know-how around clinical features and diagnosis that's present in the clinical community. It is only when these two big, complicated beasts come together will we be able to solve this problem. We have a joint responsibility to make this work for the people of this planet. The opportunity to research is remarkable. Humans will be the best studied organisms on the planet because of healthcare. We invest more in how to measure, study, phenotype, understand this organism human than any other species on this planet. And so by leveraging this huge amount of data, we have the most remarkable opportunity both for clinical research, but also for basic research. Peter and I published a paper on bioRxiv just yesterday outlining this, and we have come up with a series of reasons why studying more than 10 million humans will give us transformative views into research. So this is a huge opportunity for researchers as well as a responsibility for making clinical healthcare work, clinical genomics to work. But there are big challenges, and there's no point in ignoring those challenges. Healthcare starts from a very different place. It's one of the most regulated industries in the world. It's one of the most nationally legislated industries in the world. It is run nearly always in the national languages of each country. You don't go to a doctor in Berlin and expect to interact with your patients, or the doctor doesn't expect to interact in English, for example. And there's also scaling issues. We are moving from terabyte to petabyte to exabyte scale of these things, of the genomic data sets. And so many of the tools which worked fine and downloading systems were appropriate for the previous period of genomics, but will not be appropriate for the future. And then these different regulatory environments and different cultural ways of understanding how one does research on healthcare data means that we have to be much, much more clear and appropriate about our regulatory framework and how we access these data. And the basic solution is federation. Research data allows us, we have made great progress across the world by aggregating data for research. And we will continue to do that, I think, in the future around pure research data. But for this healthcare data, we have to embrace federation. We cannot ask countries or healthcare systems to allow their data to be moved across the world just for research. It will also be impractical, as well as, in most cases, illegal. So this is the fantasy that motivated me to make this system work. I have it in little diagrammatic form here. Here is a researcher. She's at the Sanger Institute in Cambridge, just sister to EMBL-EBI. She develops a number of methods locally, but she knows that she wants to address a much bigger cohort of patients than she can see on her data set in Sanger. Rather than downloading her code to the different data sets to Sanger, in the future she will ship her analysis to these different countries where the analysis will run in these separate places because she's been registered appropriately and has the ethical consent, but the data will not move from those different locations.
Thanks, Ewan. As Heidi said at the beginning, I've been involved with the Global Alliance from its very inception, and it's been a great pleasure. It's actually the longest I've ever done one role in my entire career, and it's probably been the most rewarding. The GA4GH mission has been slightly altered, but not in intent. So we've said from the very beginning it was about accelerating progress in human health, not just bigger, better research, and that is still there in the mission statement. And the other thing is we committed from the beginning was to the responsible sharing of genomic and health-related data. So what has changed in this slide is the middle, where we've been more explicit about how we're going to do that, in the sense of developing standards and framing policy to enable that. And you'll see that as GA4GH Connect unwinds. So back to the beginning, the original concept was back in 2012. We kicked off with a meeting that I think last night I was with 5 or 6 people who were at the original meeting in January of 2013. Commissioned a white paper that laid out the concept of the Global Alliance in mid-13, and then started a series of plenaries, first at the Wellcome Trust, then San Diego, moving through Leiden and all the way to today. And those plenary meetings have been critical to bring together a community and build this sense of shared ownership. But along the way, we took the Global Alliance from a letter of intent to a more formal organization, to a member-based organization. And as Ewan said, or I think Heidi said on the slide, without the support of the host institutions and the major funders in the US, Canada, and UK who committed to this, this organization would not be here today. The need would still be here. The organization wouldn't. I did just so want to pause and say, why would I have made this commitment to this organization, and why would I stay with it? And it's very personal. In my own family's life, we confronted a rare and deadly cancer. We were not able to overcome that cancer, but it left me with an indelible impression of the importance of sharing data, of lifting up clinical information into research knowledge. And so it's that very personal experience, which is why I joined the Global Alliance and why I stay with it. I'm not alone. We have 2,000 plus subscribers, individual members, and people who work with us in a broadest sense. We just passed 500 organizational members, and we're represented in over 70 countries. What I always point out, though, is not just the numbers on the left of this slide. It's actually the diversity and representation on the right-hand side. And we're not just an academic or a not-for-profit. We're a combination of an entire ecosystem that includes for-profit companies. In terms of a data sharing toolkit, we're increasingly going to focus on deliverables, on driving things out to where they can be practically used. We've been doing great things for the last 3-4 years, and this is a list of some of the things that have come out of the first stage of GA4GH's existence, but this is just the starting point. What we expect to see a year from now and 2 years from now is a vast expansion of really useful products that can be used, standards that can be used worldwide. This is the original structure that many of you will have seen at previous organizations, the 4 working groups. They launched over the time about 35 task teams with very specific tasks. And on the right-hand side, demonstration projects. But they were demonstration projects of the value, the importance of data sharing, because they were created at the same time as the working groups. So there was not the tight intersection that we're looking for today. So as we move from that structure to the new one, you'll see essentially we've pivoted, and our working groups have gone to the left, and we're bringing in real-world and clinical and research projects to work with us and inform that process. That's the conceptual shift. In reality, 6 technical work streams, 2 foundational work streams, 1 for regulatory and ethics and 1 for data security. And on the right-hand side, a commitment to partner engagement within that matrix and beyond. Last count, we had about 100 genomic data sharing initiatives around the world. So we may be working with 15, but the intent is to create standards that are relevant to the broader community. Clear aims here to take up these standards. So if there's a recurring word in here, it's the development of standards for data sharing. We're not trying to be the repository, and we're not trying to host the data. We're creating the standards that will enable others to do their work and be part of that cultural shift. We absolutely understand it includes extensive community engagement, but it's also the trust that has to go with that. Deliverables in terms of both technical and foundational work streams have to interface with both that driver project community and the broader one. It says on here includes 13 formal collaborations. We had 13 pre-qualified and fully identified our last 2-day meeting, but in the last week, and including the last couple of days, 2 very important and additional projects. So now it is 15 formal collaborations with these real-world driver projects. You'll see they're a mix of clinical and research. There's a population cohort in there. I think 7 of them have actually got a single country name. The rest are labeled from the beginning as international. But we checked as part of our selection process, and in every one of those that is funded and operates within a country, there is a clear intent to share data and collaborate internationally. So every one of these is an international collaborative project, whether it's funded internationally or whether it's funded within. So, just again, to reiterate, standards and frameworks enable interoperable tools for exchange of data, advance research and clinical management, most importantly for the benefit of patients, enable an ecosystem of data stewards, that sense of responsibility and ownership for the data that you hold, not just a responsibility to protect it, but a responsibility to use it, and facilitate real-world evidence generation and continuous learning. And with that real sense of responsibility, opportunity, and challenges, I'll pass back to Ewan.
So you might ask, you might be a skeptic. You might say, we do fine, we muck along, we make these things work by hook or by crook. What if we didn't have GA4GH? What would happen? Well, I really think we would not accelerate the way genomic medicine would be picked up across the world. I really think many, many patients would have a worse outcome, slower diagnoses. It would be more technical errors in this process. But furthermore, we would miss this huge opportunity of doing research on incredibly large cohorts. Really, humans are just one species. Every geneticist wakes up to this moment at some point when they look at genetic data, and you realize the only box that we should tick is human in all of the other ways we are described. And to study us, we need to study and leverage all of the different humans and systems around the world. So again, by 2022, we expect tens of millions, 60 million genomes is our conservative estimate, to be available from research and clinical care across the globe. The majority of genomic data to be collected in a healthcare setting rather than in research. A massive increase in spending that goes behind that health economics that drives that spend, and that the world of clinical genomic data research and clinical practice will just become much, much more joint. It will become a porous system. And to do this, we have to do it in a way which is consistent with the ethical approaches in many different countries. And I just have to say, the leadership of Bartha Noppers to help provide a framework where we can engage with all the different countries of the world in a responsible way in this discussion is incredibly important. In some sense, it's simple because nearly every country wants to see research happen, but on another level, it is incredibly complicated and incredibly involved. So thank you very much for listening to this. We have some lovely infographics here. Here are 4 countries in the world, all of whom are taking these steps into genomic medicine and leveraging clinical and research data together. And I think at this point, do we have time for questions? No, we do not have time for questions. Okay, all right. So you will have time to ask us questions at some time in the future. We're clearly running behind time. So we will now see a video of some of the wise men and women who give us advice. 2 of them are here in person later on, and we have 4 of them on a video now for you. Thank you.